Well, good afternoon. It is so great to see you here today. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute. And I would like to welcome you to the fourth and final session of the 2025 KHI Policy Learning Series, Exploring Medicaid Populations, Reaching Individuals Who Are Unhoused. Whether this is your first session that you're attending in the series or if you have attended all four, we are so happy that you're here. So a little bit about who we are. KHI, or the Kansas Health Institute, is a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation, and we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or stop by our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings like today's convening. Hey, and now it is my pleasure to introduce my colleague Sheena Schmidt. Sheena is a senior analyst and strategy team leader here at KHI, and she will be leading today's session as a presenter and moderator. Over to you, Sheena.
Thank you, Rebecca, and thanks to all of our colleagues who helped make today possible and this series possible, and to our speakers and panelists today. Like Rebecca said, I lead the Access to Care work at KHI, and we are pleased to be able to bring this session to you today. It's our final session of the policy series, which we've had throughout the year, and so we're excited to have this conversation with you all. To get us started, we want to hear from you. You can be anywhere today. What brings you to today's session? Please feel free to enter your response in the chat, and it just kind of gives us a good idea of what your interest level is, what questions you might have, and why you thought this was a good place to spend your afternoon with us. While you're doing that, I wanted to highlight that we have a resource guide for today's session. It has all of the links and a few references of both from the presentation from myself and from our speakers and panelists. You'll be able to access that. It also has a couple of discussion questions and a place to take notes. So if you're so inclined, you can remember, and as you think about the topic or want to explore the materials in more detail, it's there for your reference. I'll now go over the agenda for today. So we'll have an informational presentation about Medicaid and reaching individuals who are unhoused. Then we'll transition to hear from KDADs on their approach to reaching individuals with unhoused and their programs to support that. We'll then transition to having conversations with managed care organizations and how they're reaching individuals, what programs and approaches they have in place. And then we'll conclude with a panel with a variety of organizations at the state and local level who are serving individuals who are unhoused. So a great lineup of speakers and perspectives that we'll hear from today. All right, so now we'll transition, and I will tell you a little bit about some information that we pulled together related to Medicaid and reaching individuals who are unhoused. All right. So what can Medicaid do and what can Medicaid not do? So Medicaid can cover housing navigation and tenancy supports, assistance in securing housing. It can also provide home modifications for community transitions. And it cannot cover rent, room and board, except in limited medical institutions like a nursing home or long-term care facility. And so, thinking about that context, CMS does prioritize community integration for people with disabilities. So, that's where you see the allowance for home modifications come in. And they also provide a CHIP with resources through health service initiatives that may reduce housing related risks, like programs to reduce lead exposure in homes for children. So, what does it look like when we're thinking about connecting people who are unhoused to Medicaid benefits? There are a few barriers that we wanted to highlight. So, as you all know, Medicaid eligibility determination is an application-driven process. It does require an application, significant documentation, for example, personal identification, verification of assets, income, proof of those assets and income, It does create some difficulty in navigating a system, an application-driven system, and there's also other requirements that may make it more difficult if you're trying to qualify for a disability, for instance. So, given those barriers and the nature of having housing instability, it is unique for this population in an effort to obtain Medicaid coverage. Next, I'll talk a little bit about the Medicaid authorities or levers that can be used for housing related services. States can leverage a variety of Medicaid authorities, including through their state plans, waivers, and managed care arrangements to cover housing related services for Medicaid beneficiaries. States that are considering creating or amending covered housing related services can draw from many of these approaches that I'll go over now. When you're considering thinking about how Kansas might approach this, there's a few ways that they can do that. So one is money follows a person. It supports transitions from institutions to community living. It covers housing supports and additional home and community-based services during that transition. And states may partner with housing authorities for vouchers, for instance, in an ability to connect individuals from their institutions transitioning back into the community. Through this program, over 100,000 beneficiaries were able to transition into the community. And so that is one way that states have approached this in the past and now. They can do so through Section 1115 demonstrations. So waivers allow states to test housing related services. They must be budget neutral. But they're used to address housing needs for high cost beneficiaries typically, like through serious mental illness, those who have homelessness, and other specific situations. One example is California's program for whole person care. It provides housing supports, tenancy services, and supports move-in costs for individuals that meet those requirements. Other examples or other authorities can be used are Section 1915 um, options. You'll see them listed there. 1915B is managed care waivers. They can fund transition and tenancy supports. 1915C used to be covered one-time moving expenses, home modifications, household setup costs, and tenancy support. And then 1915I is similar to 1915C, but there's no institutional level of care requirement associated with that approach. So some examples that I've used 1915s are in Los Angeles and Minnesota. And so I'll go over some more examples here in a bit. State plan authorities can also be used. 1905A is targeted case management for housing access and stability. 1945, it relates to health homes. It allows states to integrate care and referrals for housing supports into their approaches. And 1915K is a community first choice. It allows Medicaid to pay for transition costs and home modifications as well. And then lastly, I wanted to talk about managed care. So states can direct or incentivize managed care organizations to address their members' housing needs using the following levers, either through care coordination, through value-added benefits, and in lieu of services. And we have a whole discussion planned for you today on how they're approaching that in Kansas. A couple of examples I wanted to highlight is one in Maryland. They have an assistance in community integration services program. Uh, the pilot program began in late 2017 with the goal of reducing unnecessary health services use among Medicaid beneficiaries by providing tenancy and housing case management services through four lead entities in Maryland. They were located in various parts of the state, including Baltimore and a few other counties. And the program was targeted for adults who meet the U.S. Housing and Urban Development's head of household definition. They authorized it under the 1115 Health Choice Waiver. And so in FY 2024, the program served over 500 people, and a recent evaluation found that 77% of participants obtained stable housing, and participants had statistically significant reductions in both ER visits and inpatient admissions. And that was aligned with the goal of the program. So that was one example that we wanted to highlight as a potential approach. Secondly, another example is in Louisiana. It currently operates four different 1915C HCBS waivers to address housing. So they have the Children's Choice Waiver, which covers housing stabilization and transition services for individuals with autism, intellectual disabilities, and developmental disabilities for ages 0 through 20. They have a new opportunities waiver, which provides housing stabilization and transition services and in cash, $3,000 per member for security deposits, kind of household setup activities. They have a residential options waiver, which covers in-home caregiving, community living supports, and one-time transitional services into the community for individuals of all ages with those conditions that I mentioned before. And then a general supports waiver, which promotes housing stabilization and transition services for individuals with autism ID and DD. So you can see there are many waivers addressing individuals with ID, DD, and autism to help support their housing needs. So now thinking about, we've kind of talked through Medicaid and how nationally approaches are being done and what authorities are able to that states are able to use to support housing. Now we'll transition and talk a little bit about how CanCare approaches housing related supports. The contracts that are in place now that were just in 20, active in 2025 now explicitly for the first time treat housing as a health related social need that must be assessed and included in care planning. So housing is now baked into the expectations for assessment, care coordination, and the plan of care development. Not that these activities weren't happening before, but they're now explicitly stated in the contracts. Um, and so I wanted to talk about how they're approaching this. So they do this in a couple of ways. One through value-added benefits. They have independent living and housing support is included in the list of value-added benefits. So they can provide assistance with housing navigation, daily life, living supports, and maintaining stable housing. These are MCO funded, so the state doesn't provide Medicaid dollars for that, but if they want to choose to do so, MCOs can fund these things. They can help members with things like finding and maintaining housing or practical things that make independent living possible, but they're not rent payments. Um, and so other ways they can do that is through in lieu of services. Housing support is one category, and so they can provide temporary housing assistance for individuals transitioning from institutions and inpatient settings, plus tenancy support and case management. And so another way is through housing HCBS. These waivers allow home and environmental modifications and transition related supports to enable community live-in. And Kansas HCBS waivers and LTSS programs can pay for these modifications and some household setup costs when needed to keep someone safely in their community. But waiver documentation again continues to state that HCBS does not pay for room and board or general living expenses, so no ongoing rent or mortgage through that program either. So that is in a nutshell what King Care offers. And you'll hear a little bit later from the state, from MCOs, and from community organizations on how it's working in Kansas now. And lastly, I wanted to talk through the governor's behavioral health services planning council. So the purpose of the housing, this council and the related in the subcommittee focused on housing and homelessness works to improve access to safe, affordable, and supportive housing for Kansas with behavioral health needs. It develops state, regional, and local strategies using evidence-based practices and equity principles, and it focuses on housing options and supportive services to prevent and end homelessness. Um, and so they had a few recommendations in their 2025 annual report related to Medicaid that you can see on your screen. One recommendation related to revising Medicaid eligibility to allow individuals with a determination of a serious mental illness or serious and persistent mental illness who meet the Medicaid income requirements to qualify for Medicaid. On average, 30 to 35% of people that experience homelessness also experience a severe mental illness or SPMI, and a lot of those individuals are served by the certified community behavioral health clinics. And so that's the reason for this recommendation, is that it would allow Medicaid to cover some of the costs associated with their care. Um, in addition, they recommended to expand waiver access by allowing homelessness as a crisis exception across waiver programs to shorten wait times and enable timely support. Um, so they recommended to work together with many organizations in order to figure out how to address this. Um, and then lastly, they recommended strengthening coordination between Medicaid providers, so CCBHCs, FQHCs, MCOs, and continuum of care communities to support housing stability and prevent homelessness amid federal funding uncertainties. And that's a nice segue into our next conversation with our presenter from the Kansas Department of Aging and Disability Services, who will talk a little bit more about some recent changes federally and how the state approaches outreach to homeless individuals. So now it's my pleasure to welcome Jonathan Pendergrass. He's the Housing and Employment Benefits Manager with the Kansas Department for Aging and Disability Services. Welcome, Jonathan. Thanks for agreeing to participate today.
Absolutely. Thank you, Sheena.
Very good. Well, I'll just turn it over to you.
Okay. Please let me know when you can see my screen.
We can see it.
Awesome. Thank you. Okay. So as stated, I'm Jonathan Pendergrass. I work for the Kansas Department for Aging and Disability Services. I am on the Behavioral Health Services Commission under Adult Services. I'm the Housing and Employment Benefits Program Manager. I'm also the SOAR State Lead. I'm going to spend a lot of time talking about SOAR today, as that's our primary avenue for connecting people who are unhoused to their Medicaid benefits and disability. A little bit about my team. At the Department of Aging and Disability Services, when I say the housing division, that does not mean brick and mortar housing. Typically gets confused with that, but we don't do anything as far as HUD vouchers or housing, actual housing, where the housing supportive services. The Behavioral Health Commission is the behavioral health authority for the state of Kansas, so we work closely with our CCBHCs, MHCs, SUD providers, and many other organizations, as well as those that are funded by HUD. So on my team, we have Ashley, who is our Housing and Recovery Project Coordinator. She is currently getting ready to launch the HUD 811 Project Rental Assistance for people with disabilities. I know I just said that we don't receive HUD funding, so what that means is we're partnered with Kansas Housing Resource Corporation for the 811 PRA, which will bring additional units to the state that are funded specifically for individuals with disabilities. She also sees our statewide initiative for Built for Zero. She's the state backbone for KDADS and works closely with Molly Mendenhall, which you'll hear from later on. Built for Zero and what that is. Destination Home is a program with Kansas Statewide Homeless Coalition that she works closely with, including their boundary spanners. Again, you'll hear more about that later. Jessica Smith, she oversees our primary contracts that are supported by the state general funds. Supportive housing funds are a program that's pretty loose on how the funds are able to be used. They help people obtain housing or sustain housing, which are at risk of losing. That can go towards rent. It can go towards the fees for the applications. It can go towards utilities, anything that's really standing in the way of obtaining housing or keeping their housing. That doesn't include medical bills or medications or anything for mortgages. It's primarily for those who are looking to just get into housing or sustain their rental agreements. With that, the individuals have to be, somebody in the household has to be have SMI. They have to have 150% or less of the federal poverty guideline for the whole household. And they have to have an imminent risk of homelessness or are literally homeless. So Option Supportive Housing Grant is another one. All these grants, by the way, or all these programs are eligible for people who do not have Medicaid and who do have Medicaid. So Option Supported Housing Grant is a short-term transitional housing that is with only a few of our CCPHCs. That's actually currently out for RFA, so we don't have a list of what that will be right now. But that grant allows individuals who are street homeless to get into a temporary housing for 6 to 9 months, and while they get their documents in order and or whatever else is the barrier to getting housed, and then also attend employment or what other opportunities they need. So PATH is a federally funded program from SAMHSA that we receive, and we are a pass-through entity to the CCBHCs. There's 5 of them currently, and that is an outreach program. And then Patrick is our employment and benefits project coordinator. That really focuses on the benefits and employment side of things. Once they are housed, we always encourage employment because that's the best way to sustain housing and to helps out with mental health conditions and just everything in life. Really needs that continuation from receiving housing. Anyway, he is our TA for the Individual Placement and Support IPS program through the CCBHCs. He's also a co-state lead for me, and then for SOAR, and then Employment First Support Employment. So SOAR, that's SSI, SSDI Outreach, Access, and Recovery. That is a program that's designed to increase access to supplemental security income and Social Security disability insurance, or SSI and SSDI, for individuals who are experiencing or imminent risk of homelessness and who have a mental health condition, medical impairment, and or a co-occurring substance use disorder. Simply put, it is a process that teaches providers how to submit quality disability applications to SSA while advocating for the assisting with documentation and appointments, decreasing the time to determination and reducing the need for appeals. A little bit of a history. It was funded by SAMHSA, and for almost 2 decades. 2006, it was they funded the Technical Assistance Center, the actual program. Recognized SOAR as a program that helps people who are unhoused get connected to benefits, which ultimately lead to housing. 2009, they began the SOAR TA Center. 2014, they launched the online adult curriculum, where we saw a lot of expansion on who could become SOAR eligible. And then child curriculum was introduced in 2018, and then 2024. As of 2024, SOAR had assisted over 100,000 cases. Unfortunately, the SOAR TA Center closed last August, which means all of the certification process, the training course, and the technical assistance ended, as well as their tracking. That is now put on the states, which we are currently working through. And Kansas was a top 10 state for many of the years that the TA Center recognized that, and we ended the very last report that came out in August. We were among the top 10 states again, so we're pretty proud of our SOAR work and all the amazing work that happens across the state through SOAR providers. So SOAR, just a brief overview of what that looks like. The critical components are 1696 is it's a form that's signed by the SOAR caseworker that allows them to become a representative for that individual that is recognized by Social Security Administration. That gives them an ability to speak for them, to make appointments, to navigate the complex application process, and that also allows them to receive all the mail that the individual also receives. And then the medical records they compile for the Disability Determination Services, which handles the medical side of the Social Security application process. So they collect those medical records for DDS, which can oftentimes decrease the time it takes to get those, as they've built relationships with medical records departments, and allows them to process that quicker than DDS can. They compile in what's called a medical summary report. This is a narrative of the entire lifetime of the individual. It really allows the case not just be a stack of papers on the desk at DDS, but allows them to see this as a human being that they're reviewing and evaluating for disability. It tells kind of the history of their family makeup, what happened during childhood and through adulthood, what has, oftentimes what has caused or led to the conditions that they're seeking disability for. And so it puts it in a nice review, oftentimes allowing the DDS to not have to request additional records or appointments. So that MSR is actually signed by a acceptable medical source, and that causes it to be considered medical evidence, giving it more weight to the case. And then the quality review is done by a mentor or supervisor prior to the TA center shutting down. A SOAR provider could send their redacted information with no PHI in it to the SOAR TA center to be reviewed, and that often would lead to better approvals on the first round of the initial application process. And then what really makes SOAR amazing too is that this is not like attorneys who receive 25% of the back pay. The SOAR providers do not accept back pay. They're often funded through the Medicaid reimbursement process or through their center. And so we believe that the funds that are obtained through back pay really need to go towards obtaining housing, a vehicle, utilities, furnishments for the apartment or whatever it might be, something to sustain them long term in their housing. I'm going to speed through a little bit as I had a shorter time here. Barriers that cause issues with obtaining disability. It's a very complex process, around 30% national approval for just typical initial applications. And in Kansas, we're usually around 68 to 70% for our initial cases, so well above the national average. And then the SOAR average nationally is around 65%, so we're usually above that as well. And then it can even be as low as 10 to 15% for individuals who are homeless, given the barriers that they face, including lack of Medicaid, so they don't get those medical records that are helping increase the chances of that case being approved. Their mailing address is always an issue because the Social Security Administration sends out their mail as well as DDS. And oftentimes it has like a 14-day turnaround time for their records that are needed or appointments or other forms. Quite a bit gets mailed out. So oftentimes if there's not a mailbox attached to that person that's dependable, they don't get their mail, they don't get their they don't see the need for those documents, and their appointments are missed. So then the notice of appointments, as I just discussed, lack of transportation to those appointments can be handled through SOAR. They can usually help connect that person to a ride for their, and sometimes that happens on Saturdays. So it's not always typical times when case managers can take them to that appointment. And then a lack of communication when Social Security tries to call or needs a in-person visit. Many times they'll need support getting there and communicating because they're not sure how to communicate in a way that sometimes is appropriate or is helpful to Social Security Administration. So the concurrent Medicaid process is how we all SOAR providers are trained to assist with this. It's required once an individual has began SOAR services. They are then connected to Medicaid through the presumptive Medicaid process. SOAR providers have a agreement, KDADS and KDHE, to allow them to submit through email, which allows, and a special team processes them, which allows for quicker communication, turnaround, and then if they need to request a reconsideration, we can do that directly. This takes away from a lot of the time spent on phones looking for information from KDHE or the clearinghouse, and then oftentimes just not being able to talk to the same person. This gives us a direct team to work with. So through that presumptive process, they can backdate up to 3 months prior to the application if requested, and if they have bills for that time period. the SOAR specific process. Yeah, and then um, all cases are monitored by myself and Patrick Nolan, or who is the co-lead. So this allows us to support our SOAR providers if there's anything that's missing or communication that's not going well, and also allows us to help identify training needs for this process. And um, then the yeah, okay, that was it. Sorry, I'm a little over my time here.
That's all right, Jonathan. Thank you so much. Lots of helpful information. Um, and please enter your questions that you have for Jonathan in the chat. I did want to talk a little bit, just if we have time for one quick question. So you mentioned a little bit about the federal funding being eliminated for the SOAR program, which can create, well, has created challenges for states and local partners working to support individuals who are unhoused and accessing disability benefits and thereby, the Medicaid benefits. How's Kansas responding to these changes, and what implications do you see for connecting people to cane care and other supports moving forward?
So that's the great thing about SOAR is it's not a program that has to have funding. It's really a process. So SOAR will continue. We are currently looking at how that certification process will happen, but for the time being, anybody who is SOAR certified is able to continue that process, as it's really about the work being done up front, as opposed to letting DDS do that work in their typical process, where it takes a longer amount of time. They do a lot of the front load and then hand off the case to DDS. So this is an ongoing service that's being provided through Kansas, and we do look forward to continuing that certification whenever we determine what that will look like.
Thanks so much, Jonathan. And I will direct you. There is a question in the chat if you want to respond to Elizabeth directly, if helpful. All right, I'm going to move us along. We'll go ahead and bring back up our slides and move us along to the next agenda item. Thanks again to Jonathan and all of the work that KDES is doing to reach individuals who are unhoused. Now we'll transition to our conversation around cane care with our managed care organizations. Our featured panelists today are Stephanie Klein, who is the Senior Clinical Program Manager of Housing with United Healthcare, David Fields, who is the Housing Resource Specialist with Sunflower Health Plan, and Beth Russell, who is the Housing Program Manager with Healthy Blue Kansas. Welcome, everyone. All right. Well, thanks again for all of you for joining today. I had just to start us off. Um, how are your organizations working to enroll, engage, and retaining can care members who are unhoused or have unstable housing? And what are you hearing from members about barriers to or accessing or maintaining coverage who are experiencing homelessness or unstable housing? We'll go ahead and just start with the first person I see on my screen, Stephanie.
Oh, good morning. Can you hear me?
I can,
All right,
yes.
just making sure.
Welcome.
Thanks for having me today. When we talk about kind of some of the barriers that we've heard from members that are unhoused or unhoused populations, I think one of the things that kind of stands out is members being able to maintain waiver services if they are homeless, and because some of those waiver services are dependent upon utilization. And so when we have members that are unhoused, they are residing in shelters, or maybe they are transient and they're not utilizing this waiver service. So being able to maintain the waiver for a homeless member becomes a little bit more challenging. Um, I definitely would say that's one of the barriers, as well as I think Jonathan on his slide identified several key things that we see at an MCO level in regards to ensuring that people have accurate mailing addresses to continue to ensure that their Medicaid applications, their Medicaid documentations stay up to date. With transient populations and having a lack of mailing address, I see that being a barrier, and staying in touch with our homeless population in general, for us to coordinate care and to ensure we are making sure they're referred and connected to the proper services to stay engaged in the Medicaid plan.
Thanks so much, Stephanie. David, any thoughts you'd like to add?
Yes, I can you hear me?
I can, yes.
Okay. Yeah, so I would agree with Stephanie on a lot that she did mention. Also what I have found with some of our members is that as of late, um their homes encampments have been moved around quite a bit, which limits some of the case manager's contact with them because now you have to go re-find them. Where before we kind of knew where to locate them at, and that becomes a barrier there because they're not utilizing those services any longer. Some of them choose not to utilize some of the shelters or the services there, so it does make it a little more difficult for us to find those members and able to, in order for us to be able to provide the services to them. The other area that I have noticed a big barrier for me is those coming out of with mental health barriers. Housing those with mental health barriers, whether they're coming out of institutions, whether they're just coming from homes. Um, the amount of housing that is accessible to them is limited. And they are, some of them have barriers where they're unable to live in um, just traditional homes, housing. So it would need supportive housing and that sort of thing. And so that also, I think, is a barrier that we have.
Thank you, David. And Beth, go to you.
Sure. When we are thinking about barriers and how we're addressing those, we're thinking about three critical areas. So we are thinking about enhanced access and communication. You heard some of that from Jonathan. We're thinking about collaborative care and coordination. And we're also thinking about innovative support programs that are addressing unique nuances for this population. And so for enhanced access and communication, at Healthy Blue Kansas, we've implemented an easy-to-use online platform, the Sydney Health app, which allows members to enroll, manage accounts, and access benefits. We also have the Get Connected to Health initiative, which provides high-quality smartphones preloaded with the essential health apps and unlimited connectivity. This ensures that members can stay in touch with care coordinators and services that they need, regardless of that situation, regardless of their housing situation. For collaboration, for collaborative care coordination, we have a platform, Find Help, where we are working together with our community engagement team as well as community health workers that are on the ground. They're at community activities such as food kitchens and shelters. And this direct approach helps us to build trust and overcome those barriers by being in the presence, by being right there with the people that are having the need. And then for innovative programs, we are working with not only waiver members, but we're also working with general Medicaid that are at risk of housing instability. And we are providing flex funds, home repair support, and also a housing stability program where we have very specific care guides that can come in and help reduce those barriers by providing support with identification documents, landlord and lease agreement support, employment services, and effective strategies for stabilization. We also offer emotional well-being and substance use disorder support through our digital toolkits and mobile platforms that are available through the Sydney app. So we're trying to be exhaustive in approaching these barriers.
Thanks so much, Beth. And Stephanie or David, are there any other pilots, incentive programs, or approaches that you all are using um, that align with this approach or different from that approach that you wanted to mention?
Yeah, for me, for us here at Sunflower, we have what we call our Life Share team, which is what I am part of. We cover three major areas. We have our social determination of health team, which is like myself, the housing specialist. We have employment specialists. We also have our social determinants of health specialists that are going to cover our food, transportation, utilities, program coordinators, that sort of thing. We have also our project and search and work steps teams, because so many people have the misconception that if someone's on Medicaid, they are unable to have a job, and that is not true. They are able to work, they are able to make money, and we have our steps and our work programs that can that we walk with our members through and allow them to be more self-sufficient, and a little more uh, um, uh, um, um, I'm so sorry. I can't. A little, just a little more self-sufficient is what I'm trying to say. Next to that, though, we with our Sunflower Life Share team, we also have our systems liaison team, and that covers our justice side, our foster care side, our tribal partners. We have a tribal liaison who works with our tribal members, who also, as part of our added value benefit program that we have. We have schools. We work with our schools and our peer supports. On our third leg of our holistic approach with our life share team is our person-centered training experts. With our life share team here at Sunflower, the main thing that we believe in is person-centered approach 100% of the time. So what that means is that everything is built around our member. No decisions are made without our members' involvement. That is person-centered. So things like that are covered with that. It was our person-centered thinking. We have life courses. We have quality of life. With our Project Echo, we have with our Project Echo, anyone is able to have care coordination with Sunflower. All they have to do is ask. It's they can anyone can get it. So that is something that sometimes it doesn't always happen for members, but with Sunflower, you can always have care coordination. All you have to do is ask for that. Okay. And of course, we also work with autism, our IDD members, and behavioral health. We also have worked with our waiver wait list members as well. So we work very closely with many different aspects of our community, from everything from those that are homeless, those that have mental health barriers, those that are coming out of institutions. We have different programs to fit all of our needs. And like I said, the main thing is that we focus on a person-centered, holistic approach.
Thanks, David. Stephanie, I'll turn it back over to you.
Sure. Yeah, absolutely. So yeah, at United, we do a lot of some of the similar things in regards to trying to really assist our homeless members by we have some additional round trip transportation to assist members that are not medical based so they could get to applying for housing, they could look for employment. So David talked a little about the social determinants health department. I sit on that strategy team as well for our United Healthcare. And within the social determinants of health, we focus on everything from ensuring that our nutrition aspects are met for our members. We work and do mom's meals, which is being able to provide meals for post-discharge for our new mothers, but we also use that incentive as well for individuals that are going from homeless to housed to be able to set them up with nutritional home meal boxes when they first move in. We try to assist them with kind of getting some movement items at when they transition as well, from homeless to housed. We offer for some of our members, especially on our waivers, they have additional services like pest control to help them maintain housing. OTC rewards programs. We've partnered with Walmart as well for some Walmart memberships and delivery of items for members in their homes. We've also worked very closely with and this might be something we get to in a little bit, but really working closely with our continuum of cares and our balance of state to be able to have data exchange and be able to utilize the homeless management information system to be able to see what members are coming through the system, identifying as homeless, being able to work with the continuum of cares and the balance of state, be able to identify who needs more resources, who's working on our end of the table, who's working on the community end, so we can collaborate better and addressing those homeless members that are actually coming through the system, because it is kind of a large amount that utilize the system, and we want to make sure that those people don't remain in there as unhoused and that we're getting them connected. So we do partner with our community providers. We have also provided some funding for our community providers to be able to provide more support for individuals that are needing to get housed, to be able to assist with such things as security deposits, landlord negotiation, in regards to needing to be able to pay a little bit of remediation for those landlords, whatever the community partner wants to provide in order to be able to support those members to stay housed. So we've really worked collaboratively with our community partners to be able to provide some greater support to maintain housing for our members.
Thank you so much, and thanks for that terrific overview from all of you. I did want to note there's a question in the chat. Uh, from Elizabeth. She's noticing that with a lot of the clients that they assist, their biggest need is for dental care. And so, can you talk a little bit about any support related to dental care for individuals who are experiencing homelessness?
Sure, we have a value added benefit for members that are 21 and older, where they can get an additional $500 per year for specialty services for dental services. And we also have a sensory kit for members that have autism that can kind of help desensitize as they're getting ready to
Oh,
go into the dental services.
okay, thank you.
Yeah, and Sunflower also pretty much offers that same thing. We have a dental plan for adult dental checkups with a $500 annual budget as well, and that includes cleanings, X-rays, and exams. We also um, something else I didn't mention before is we have something at Sunflower called Start Smarts for Babies, where Sunflower will walk with a pregnant mother from the time that they know that they're pregnant till 1 year after the baby has given birth. And it includes free car seats. It includes a registered nurse being assigned to that member as well, the entire time through that pregnancy and a year after the child is born.
I kind of want to say ditto on some of this stuff, but United is the same way. And we can actually provide some of our value added
Yeah.
benefits for our dental, if that would be helpful, because that is public information. But we do have, even in 2025, some additional value added benefits for our dental programming. And I know that David just talked about his maternal and steps in our pregnancy program, and we have supports as well for our maternal and our first steps program. I'm even doing pack and plays, but I don't have all the dollar amount details for our value added for our dental, but we can definitely provide that.
Mhm. Thanks. All right. I'm gonna transition and talk about you all mentioned partnerships and working with communities and meeting people where they are. Um, Thinking about that, how specifically are you partnering with community-based organizations to reach and build trust with unhoused populations? And what could better help MCOs better collaborate with those community partners who work with individuals experiencing homelessness to improve navigation or the use of their can't care benefits?
I think that this is a big step here today. I think that getting innovative, you're hearing Stephanie and David and I all talk about looking at how can we be innovative to break through barriers, but also you've heard Stephanie mention the balance of state and the continuum of cares, as well as the community-based organizations. It is getting this information out. So oftentimes someone will have Medicaid and not know what these benefits are. And as much as we can tell them, if someone is in trauma, if they're in crisis, it's hard to take that information in. So being innovative to work together in partnerships and share our information is really important. And we have amazing continuum of care organizations in the state of Kansas that have done a good job trying to get this information out.
I would have to echo Beth on that. I think a lot of it's just getting in front of the people and hearing about that. I've spoken at I participate in all the COCs, and I think most of us do as well. And really speaking to a lot of those individuals, you'll be intrigued to hear how many are not aware of the supports and the services that come from the managed care companies, and especially if someone sits on a waiver, what additional supports that they have at their hands that they're not utilizing. And there are even different housing vouchers in the community that require, for example, an individual maybe to have case management services, and unaware that typically at the MCO level, there is a case management level of service that that individual is receiving or can receive that would make them eligible to be able to be referred for certain housing vouchers. And so, I think a lot, Beth really talked about just community awareness and education and making sure that we are a presence at those tables in those rooms. And being able to really collaborate and communicate with all the providers around the state. I know there's only one of us at each of the health plans, but we do our best, I think, to really try to get that word out there.
Yeah, and for me, what I like about my colleagues here too is we all, in our own way, we serve our communities in different ways. I also sit on the Kansas Housing Advocacy Network steering committee, and the one way that I feel that I would like to see some things improve is I like that no wrong door method of collaborating with other organizations to track the needs of those that are in need of housing. And one way I feel that we can improve on some of this would be to utilize the Z codes a little bit better. If we can get primary care physicians to utilize the Z code a little bit more often, or dentists, as an MCO, we would be able to get that information a little bit quicker. And when it comes to housing and health for our members, the sooner that we can get that information, the sooner we're able to act on it. If the sooner we can act on it, the healthier we can keep our members. So look at it this way. If you get a member that goes to the doctor, let's say, and they go to the doctor and they tell the doctor that they don't have a home, they don't have a place to live. That doctor now can put that Z code in and let the MCO know that this member has stated that they don't have a home. What does that do for the MCO? That that triggers the MCO to now look at, if you don't have a home, you may not be eating correctly. If you're not eating correctly, then you're probably not getting proper nutrients. If you're not getting proper nutrients, you could bother your teeth. If you have bad teeth, we know that affects your heart. So it's a snowball effect. And we would like to see more collaboration, and we think that things through collaboration and utilizing some of the systems that we already have, maybe a little bit better, could also help benefit those that are in the homeless right now.
Thank you so much, David. Any other thoughts to add? All right. Well, thinking about this topic in general, assisting individuals who are homeless, is there one parting thought or something that keeps you up at night, that you want to mention and share with the group?
I think a good parting thought is just listening to the three of us talk, and you can feel our passion as we're sharing. And I think we have colleagues online that um, want to value dignity and health equity, and that robust collaboration with the community partners is so crucial. Enhancing our data sharing, coordinating our care models, innovating our pilot programs, especially with the current changes taking place, and being sure that we're finding platforms like this one to be able to communicate that. So I thank you so much for having this webinar today.
I also would echo maybe the fact of, for community providers, don't be scared to ask. I mean, don't be scared to want to engage in the conversation with the managed care companies, even if it's something innovative. It's a strategy to say, hey, I've thought about this, and is there a way that you can come on board to be part of this new strategy, or this is what we've been thinking about at the community level that we're needing. Is there any way that you can come on board and help us partner with that? Because I think a lot of the work that we want to do is looking at collaborative and community partnerships and engagement with our providers. And I think we want to engage in more of those conversations. And so I think, people I think get scared to ask, or it doesn't always have to be funding related necessarily in discussions. There's things that we can also come to the table and be able to be supportive and come aside, community providers. And I think just having those conversations, and don't be scared to ask.
Absolutely. I think there's a couple things for me that probably would keep me up at night, but that's not hard because my brain's always going. But one of the things that keeps me up at night is the fact that I worry sometimes that uh, in this environment, sometimes we get a little too focused on just our own little corners, and I think that can hurt our members. Um, we need to make sure that we're collaborating and that we're reaching out to other agencies when we need that assistance. The other thing I would like to just point out is just as your MCO, Sunflower wants you to know that we are here for you. We are here for your members. And if you may not think it's something Sunflower or United or Healthy Blue can help you with, try us. You might be surprised on the resources that we have. And here's the thing: we're here for our members. We're here to take care of the members. All three of us, we pretty much, like Stephanie was saying, we pretty much have the same benefits, but with a little slight difference here and there. But the thing that we want the most is we want to get our people housed. We want to make sure that they have a right and a roof over their head. So that's what keeps me up at night, is that maybe someone doesn't know to utilize us, but just utilize us. We're here for you.
Well, thank you so much, and thanks for participating today. It's much appreciated, and it's always, really important to learn about everything that's available to Can Care members and how it's working at a practical sense. So really appreciate your time and your efforts and the roles that you play for improving the health of Kansans.
Thank you.
All right. Okay, so now I'll bring us back and we'll jump right into our last panel of the day. Last but not least, certainly. I'm joined by Becky Gray, who's the Executive Director of Building Health, Inc. With Community Health Center of Southeast Kansas, Molly Mendenhall, who's the Director of Statewide Initiatives for the Kansas Statewide Homeless Coalition, and Doug Wallace, who is the ESG Home ARP Program Manager for the Kansas Housing Resources Corporation. Welcome. To start us off, I'll just and remind everyone in the chat, if you do have a question for any of our panelists, please put it in the chat or use the Q&A feature. We will try to address them as they come in. But to get us started, could each of you briefly describe your role and how your organization supports individuals who are unhoused and accessing or using CanCare? And I'll go ahead and start with you, Becky.
Hi, thank you for that introduction. Thanks for inviting us into this conversation today. As you said, I'm the Executive Director of Building Health, Inc. We are a nonprofit subsidiary of the Community Health Center of Southeast Kansas, the largest federally qualified health center in the state of Kansas. I serve our community by really looking at the macro level. So I facilitate a lot of capacity building among our continuum of care in the region. And then we also provide some direct services. So my staff does coordinated entry assessments. When they do those coordinated entry assessments, they create housing stability plans that always include access to health care.
Thanks so much, Becky. Molly, I'll turn it over to you.
Hi, my name is Molly Mendenhall. Like Sheena said, I'm the Director of Statewide Initiatives at Kansas Statewide Homeless Coalition. You heard a little bit about my programs earlier when Jonathan was presenting. I oversee 3 of the boundary spanners here in Kansas. They help transition people out of the NFMHs under our Olmstead settlement. I also do Built for Zero, and I have the Destination Home program as well. But Kansas Statewide Homeless Coalition is the balance of state lead agency for the continuum of care programs. So we are kind of a funding pass-through for HUD funds through the COC programs. We're also a coalition of member agencies, including KHRC with Doug, Becky with Building Health, KDADS, and a ton of other service providers for people who are unhoused. And so we do a lot of work connecting people to Medicaid, to SOAR, to the FQHCs. We're just kind of a statewide connector of agencies, of individuals, of systems, all of that kind of stuff.
Thanks for being here today, Molly. And Doug, I'll turn it over to you.
All right. Thank you. And it's a pleasure being here today. Thank you for the invitation. So as I was introduced, I am Doug Wallace. I'm the program manager at Kansas Housing. We are not like a lot of the other presenters here. So Kansas Housing, we do not provide any direct services. We are a public corporation that serves as the state administrator for multiple federal grants or multiple federal funds. So within KHRC, we have a department that receives federal dollars that works with developers to create affordable housing. We have a compliance and a contract administration department or division that works with federal housing programs. And then we have our Community Solutions division where I'm housed. And this is a division that has programs like the Emergency Solutions Grant, which is federal funding that we pass through to community agencies to provide support and services to people who are unhoused. So those who are currently experiencing homelessness or those who are at risk of becoming homeless. And we have funding for the HMIS, which is our data system used by the Balance of State Continuum of Care Network. So KHRC, we receive that primary funding and use it to pay for the system and licenses. So we do a lot of the administering these federal grants. So while we don't do direct service, what our role is more around technical assistance, making the funding available to the community agencies, providing that TA, providing guidance and compliance, just ensuring that that agencies are using the funds to connect to their to connect with people who are unhoused. And some of these programs, like our Emergency Solutions Grant and the Home ARP, which is home dollars funded through the American Rescue Plan, these are resources that couple services like ESG can be used to provide some housing assistance, homeless prevention or rapid rehousing assistance to keep someone in stable housing. But it's also used to pay for supportive services to help connect the individuals with mainstream resources such as TANF and SOAR. So with ESG, with Home ARP, a lot of we use the funding, or the funding is designed to help connect people to those resources they need, including Medicaid. And then with ESG, we have it in our policies that if you're receiving these services, you have to provide these case management or this housing stabilization services to help help your clients connect to those resources. So I guess that's kind of where we come in, is more around we're the funder, we're the resource, but we are an active member of the continuum of cares. We are actively participating in multiple community meetings to help get the word out about our services, as well as just helping educate the public about our resources.
Thank you so much. And I think that's why we have such a great perspectives today. You have kind of like a state perspective, a community perspective. And so as we address the questions, it'll definitely be interesting to see the synergies. All right. How do your organizations coordinate with, and you kind of touched on that a little bit, but if you have anything to add, how do your organizations coordinate with health providers, case managers, MCOs, shelters, or other outreach programs to support Kin Care enrollment and care continuity? And from your perspectives, what's been really working well in terms of those collaboration strategies?
Well, I'll jump in since So again, we are the funder, so but we are an active member of the continuum of care. So that's how we are connecting is we are attending the continuum of care meetings. We are making our funding available throughout the state. Well, the balance of state continuum of care and within our jurisdiction. So with our funding, we have shelters that apply for our funding. We have um, nonprofit agencies who use our funding to do street outreach and to connect with people who are experiencing homelessness. So what I think is working is these type of meetings where we're sitting together and we're collaborating, we're talking about um, how do we best serve people who are unhoused. And I think that I've been lucky to be a part of some of these groups that are at the table who are really brainstorming of how do we best tackle this issue of people who are unhoused in our communities, and how do we share information and just work together to do this. And I guess that's the success I see in our the continuum of care meetings is people come to the table wanting to help each other and wanting to create a better situation.
I would echo what Doug said. This idea of a continuum of care, the balance of state continuum of care, is progressed so far in the last decade or even 15 years, where it used to be something you had to attend. Now it is something like we're all eager to work together, even to the point, at least in Southeast Kansas, where we collaborate on which funding streams that we're going to be applying for so that we don't duplicate services and we don't necessarily compete against one another. So I think that's how we stay engaged with other service providers. I also think that the landscape has changed, in particularly, I think, since the pandemic, where we're seeing such an increase in need for these resources that unusual community partners are now starting to be more usual. I will say that. So increased collaborations with law enforcement for certain, and other medical providers outside of the FQ that I work for. We're in a unique position that uh, I'm employed by a federally qualified health center, so it's very easy to get um, our program participants into the clinic. Whether or not they will stay in the clinic is a different story, right? Because a lot of our participants are very um, adverse to institutions. There's a significant distrust there. But in terms of collaboration, I have to shout out to the Kansas Statewide Homeless Coalition because they were really bringing a consistent language, a consistent approach to data collection and analysis, a consistent approach to not case management, case conferencing, right? And how we operate our COC on the regular. So as a state, I am so incredibly proud of how homeless services are provided here. Kansas is rocking it.
And I think in the last probably 5 years, we've made a concerted effort as continuums of care across the state to include more physical health, and mental health resources outside of the CCBHCs. So involving places like the people like the MCOs and the FQHCs. All of our MCOs are members of the Balance of State COC, for example. Some of them sit on our steering committee to help inform and make sure that what we do is beneficial to the people that we're providing services to. We are trying to make connections with, like Becky said, some of the non-traditional like healthcare partners with like mobile integrated health units, any sort of things that are coming out of the fire departments or things like that. We're trying to get them to the table, as well as working with our hospitals. But I love our MCOs. I feel like I work with them pretty often. because I oversee our boundary spanners. And so our boundary spanners make sure that our MCOs are at the table when people are transitioning out of the nursing facilities for mental health. And so they are engaging not only the housing divisions, but also the transition teams to make sure that people are supported when they leave and they're not discharging into homelessness and they're not at risk of homelessness once they discharge. And so having those value added benefits and those transition teams and all of the things that the MCOs do have been really helpful. One of the first things I ask people when they're looking for resources is, does this person have Medicaid and who's their MCO? And you should call them because they have really great programs that I think not people don't always know about, but they're more helpful than a lot of people think that they are.
Thank you so much. And thinking about, yeah, how you're addressing some of these barriers or challenges, or talking, Becky, about you said, maybe individuals have distrust of systems. From your experience, um, where do unhoused individuals most often encounter barriers with Medicaid or accessing healthcare? Is it at enrollment or with documentation or transportation? I know many people today we've discussed a few of those items, or is it something else? What do you see?
In the population that we work with in Southeast Kansas, I made some assumptions about. Um, I was corrected by those on those assumptions by a survey that a public health master's student did at a shelter that we had going for a while. And the number one thing that the population using that shelter wanted was to learn how to read. So I think that one of the largest barriers is the complexity of access. So I would, maybe look at an opportunity for our MCOs to understand how low the literacy level is of our unhoused population, not just written literacy, but also technological literacy. So having an app for that might not help as much as it could help, myself, Doug, or Molly. Um, I think some other barriers that I see in that distrust of institution, it's a lengthy process to sign up for benefits. And if I'm accustomed to being outside all of the time and now I find myself under fluorescent lights for an hour and a half and I really want a cigarette and my leg can't quit twitching, I bail out. I lose interest and I'm done with the process. So our staff tries to break down the paperwork into manageable bundles, or sometimes we meet at the park or another place that's more comfortable for our clients, just to kind of help them move out of that institutional environment where their anxiety levels go up.
I think one of the biggest barriers we see is the wait times to once you've applied to get the Medicaid or the SSI, and especially with SSI and SSDI, the repeated denials that people get before acceptance, and having to navigate filing appeals or finding a lawyer or trying to figure out what did I miss submitting, sometimes without help from providers because of that distrust. Also sometimes because of provider turnover. So there's that wait time, they get really frustrated and they give up. And to be honest, the providers get really frustrated and want to give up too because
Mhm.
it's so difficult to access it in the first place, just from some of those like federal um policy barriers that have been set.
So I would just add that I think, Becky, you said the complexity of it. People who are experiencing homelessness or those who are at risk of becoming homeless, so those who are unhoused, um, their life that's a crisis. It may not be a mental health crisis, it may, or a substance use crisis, but they're in crisis mode, and trying to navigate these complex systems is a real barrier, and it takes sometimes it takes somebody to walk alongside them to help them through that process. And I love the SOAR model.
Mhm.
I really do. I'm glad that Kansas is continuing SOAR, even though the fundings for the TA center is going away, because that is a perfect example of what's needed to help connect someone who's homeless to benefits, because it's a complex process. And when you're homeless, you're bouncing from place to place, or you don't have any documents with you and you're in a crisis mode. And so it can be a very challenging situation.
If I could add one more instance of what I see is even after we have access to the insurance, access to the medical providers, there's typically a very long wait time, and especially in rural Kansas, we have a lack of medical providers anyway, and most of the medical conditions, most of the conditions that are being faced by our population who's unhoused are fairly acute. And a 4-month wait to the doctor's appointment, I mean, may as well be a million years. So at our FQ, we're utilizing walk-in clinics for that. And we do have some providers that we consider specialty providers that will engage via telehealth so that we can cut back on some of those wait times and get people to see providers earlier. But that is, I think, it's another one of those distrust of institutions, right? Like now I have the insurance and I still can't get a hold of a doctor. So
Yeah, many facets to the issue. Thanks so much. A rich discussion. So thinking about those policy changes or practice changes to respond to some of the barriers, um, in what ways, thinking about the challenges or the barriers that you thought, like, have you been able to inform policy or practice change either at the state level or even at the community level? Could you talk a little bit about that for those who feel comfortable answering?
Mine will be a real brief response. So KHRC, we are an active member of the Governor's Behavioral Health Services Planning Council, which is it's a advisory council for KDADs. And then we're an active member of the subcommittee on housing and homelessness. And so, that's how we are trying to help guide policy, is by providing recommendations and being a part of those conversations. So thanks.
Yeah, so here at Kansas Statewide Homeless Coalition, we do a couple of different things. We are also part of the subcommittee on housing and homelessness. This upcoming year, I'm the vice, or this year, I don't know, we had a couple of changes. I'm the vice chair of that committee, of that subcommittee. I've been on that subcommittee for the entire 3 years that I have been in this position. We also co-founded the Kansas Housing Advocacy Network with United Community Services of Johnson County, which is their lead agency for their COC. And so we do policy priorities, legislative testimony, trainings, all sorts of advocacy things, Capitol Hill Day, for anything housing and homelessness related. And then Jonathan talked a little bit about Built for Zero earlier, and how Ashley is the state backbone side of Built for Zero. Kansas Statewide Homeless Coalition is the other half of the backbone, including myself. And we have a state strategy team that's comprised of a variety of high-ranking people at state agencies like DCF, KDHE, corrections, KHRC, like all of these kind of big players at the state level that can make some of those policy changes to reduce barriers. And so we meet with them. We'll start meeting with them regularly in January to talk about barriers and how they can help decrease or eliminate those for people who are experiencing homelessness in Kansas.
it's awesome work that you all are doing. I just got a shout out again to KHRC and the Statewide Homeless Coalition. You all are fantastic partners. In the out in the rural, it looks a little bit different. Our advocacy efforts at BHI are really focused on how we can increase the housing stock. One of our biggest barriers after people do get a voucher is finding housing that has the quality standards that it needs to accept the vouchers, or having landlords that are willing to participate. And so we are working to increase density and create some housing that's owned by us as an organization that we can be the landlords of. And we're facing antiquated zoning strategies where single family 3 bedroom, 3 bath house on 2 acre lots is what's really promoted. And that's not what we need to increase affordability or walkability, or, address the built environment as appropriate at all. We also, I think in rural Kansas, really enjoy knowing our neighbors. So I run into our elected officials, at the Christmas parade this last weekend and things like that. And we meet regularly for coffee, just to talk about, what's occurring in Topeka. They share their perspectives, and I talk about what's occurring on the ground down here, and share some perspectives that we could hear. So I think it looks a little less formal in the rural, but I think that when the boots are on the ground and you're addressing local policies to make it easier to build, it seems to be where our best efforts are.
Thank you for sharing that perspective. And just to, any final thoughts or any nuggets of advice you want to share as we think about how Kansas is addressing um, healthcare access, specifically Medicaid for individuals who are unhoused?
I would just say get involved with your continuum of care that's in your catchment area. We have 4.5 here in Kansas. So we have Balance of State, which covers 101 counties, mostly rural. And then Douglas County is part of our COC. And then there's one for Johnson County, one for Wyandotte, and one for Wichita, one for Topeka, and then Wyandotte is part of a bi-state COC with Kansas City, Missouri. So just knowing the resources that are out there for homelessness, I think is really important, and having your voices at the table with what you can offer and your specific knowledge base, I think is really important.
I would echo what Molly just said. Just this conversation alone has been really, I've learned things, thank you, from our MCOs and their representatives. I would love to see more training from the MCOs to the COCs. So many acronyms. I'd love to see that training, though. I also think what David mentioned about using Z codes more is something, it's a rabbit hole that I just discovered, and I can't wait to go down it. When I think about the funding that we try so hard to receive, and that KHRC tries so diligently to distribute equitably throughout our communities, it's not enough, right? The funding, the resources don't match the need. And so the ability to have staff bill for the activities that they're undertaking can help spread out the quote unquote homeless dollars that are available to us, and make us a little bit more sustainable. So I'd love to learn more about that.
And I guess I would just say ditto to all of that. I think participating in the continuums of care and having your voice heard, but I guess I would also say is share your story. Funders need to know what the resources are and what the barrier, or what the challenges are and what the barriers are. So sharing your story, sharing success stories, sharing what those barriers are, getting the word out, I think is incredibly important.
And talking to your legislators. Please talk to your legislators. We have some really good bills that are supposed to come this year regarding housing, including, tenant rights, being able to work with code violations, safety issues that are bipartisan bills. So we have high hopes for them. So look out for those and talk to your legislators about how important they are.
All right. Well, thank you again to all of you for providing your insights, your perspectives, and for your role in supporting individuals who are unhoused in Kansas. Much appreciated. I know it takes time out of your day to participate, but we really appreciate it. So now I'll bring us back together and we'll do our closing remarks. I'll turn it over to Rebecca.
Awesome. Thank you so much, Sheena. And yeah, thank you, Sheena, for moderating today's session. And a big thank you to all of our speakers today, Jonathan, Stephanie, David, Beth, Becky, Molly, and Doug, for joining us today and sharing all of your expertise and insights. We really appreciate it. And thank you to all of you who are joining us today as attendees. We appreciate you taking the time out of your day to join this conversation and learning opportunity. We want to be able to make sure to continue to design events and convenings that are meaningful for you. So please take a moment to scan this QR code, or you will find the link for the survey also in the chat to share your thoughts and feedback about today's event. We are looking, ahead to 2026, just around the corner, for future series, and we would really love to design those based on your needs, your interests, and questions. And so feel free to scan that QR code, and you can also grab the link in the chat. And then also in the chat, we're dropping one more time the resource guide. This is an interactive PDF that includes many of the resources that were mentioned today, along with some discussion questions that you can use to guide your own reflection or guide team discussions at your organization. You will also see some additional links from speakers on the second page and a space for you to take notes. So make sure to grab that PDF, and it will also be on our website in about a week. And then, as always, we invite you to check out our website, khi.org. You can see what upcoming events we have there. We have one coming up this Thursday, our second annual Health in the Plains Summit, as well as federal policy updates that we put out routinely and other publications and reports. So feel free to check it out. Lots of great information there. Okay, and with that, thank you so much for being a part of the very first KHI Policy Learning Series. It's been a really great year exploring Medicaid in Kansas. We appreciate your time and commitment to this learning opportunity. We thank you and have a wonderful afternoon.